Good evening, everyone. We are so privileged and honored to come together and tonight to really discuss health equity, but more importantly, affordable health care and also access to health care. My name is Robin Anderson, and I am the Executive Director of the Ministerial Health Fellowship, as well as a grateful member of the Health Equity for the People, by the People. And we are so grateful and thankful to this organization for how we have come together, because we do believe that it takes all of us, that we are in this together as we work together to advocate for affordable health care. And especially it fits in with our mission as the Ministerial Health Fellowship to address health disparities, as well as to advocate for policy changes for people of color. And so I'm not going to be in between these great panelists, and I'm not going to take time because they will be able to speak for themselves. We have a great group of panelists that are here tonight, and speakers, and also pioneers in their own right. And so I'm going to ask them if they would introduce themselves and also tell us about their organization, and also why they're here tonight, and why is it important that they speak tonight about affordable health care, as well as access to health care, and why it's important that everyone should have health care. So we have with us Dr. Brinkley, who will begin, will be our first speaker, and followed by her will be Sarah Lemaster, and then we will have our speaker Sylvia Cooper, and then Frank Cruz, in that order. And then I'll be back with some questions for our panelists. Dr. Brinkley.
Good evening, everyone. Thank you to our moderator. So good afternoon, everyone. My name is Ashika Brinkley. I'm the owner of Sovereign Brinkley Consulting, which is an organization that provides training, monitoring, and evaluation services for public health and higher ed institutions. I'm also on the faculty of Goodwin College, a public health faculty of Goodwin College and the University of Bridgeport. And I'm also the board chair of the Connecticut Women's Education and Legal Fund, which, as you know, has taken a leadership role on the issue of paid family leave. So really passionate about that. Right now, we're a Black woman-led organization. Both our executive director and our board chair are Black women. So very proud of that. And I'm just passionate about issues of health disparities, health equity, and health justice. My research focused on the health behaviors of community health workers, and I myself am a certified community health worker. And if you know anything about community health workers are experts on social determinants of health. And so, you know, if we can get a little bit further upstream, maybe we can tackle some of these issues that affect our most vulnerable populations more effectively. So that's really what I'm passionate about, and try to, you know, whenever I show up, you know, I really do try, especially for women and girls, you know, try to help address some of those issues.
Thank you.
Do you want me to go next?
Yes, in the order that I read, would be Sarah, then Sylvia Cooper, and Frank Cruz. Yes.
Great. My name is Sarah Lemaster. I am the manager of government relations and public policy for the Community Health Center Association of Connecticut. I'm actually on vacation in San Diego right now, but I can't think of a better way to spend my afternoon than with all of the incredible people here, and it's certainly a pleasure to serve on this panel. So the work that Connecticut's community health centers do, there are 17 health centers throughout Connecticut with over 100 locations. They also operate over 200 school-based health center sites. And community health centers are really the first line of defense in helping our communities stay strong and healthy. We were the places where a lot of people turned to at the start and throughout the duration of the COVID-19 pandemic. Collectively, our health centers serve over 400,000 patients every year. Many health center patients identify as people of color. I think 40% of our patients identify as Hispanic or Latino, and 20% of our patients identify as Black or African American. And additionally, if you look at the other sets of our numbers, we overwhelmingly, a lot of our patients suffer from a lot of chronic illnesses that I think can be better addressed through better social not social behaviors, I'm sorry, through addressing the social determinants of health. If we work to make our communities stronger and healthier, it will improve health outcomes. But it's also, I actually had this experience on the playground with my child the other day where he was playing and there was this girl and they were having a great time together, and her mother told her she couldn't play that hard because she had asthma, and it broke my heart. And I was just like, we need to do better. We have to do better for our children. And it's, so anyway, so the work that Connecticut's health centers do, they offer same-day primary dental and behavioral health care to all. They offer care to every single patient that walks through their doors, regardless of ability to pay. I know I've had conversations with several members on this panel about the type of care that's offered at health centers and accessibility to care. So the way that community health centers work is they offer care to everyone. They don't turn patients away. So, and if you're not able to figure out, you know, if you don't have insurance or you don't qualify for Medicaid, they find ways to give you access to resources to help you pay for the care that you need. They're on the front lines in terms of, they've sort of been doing the work of health equity for the last 30 years. So I remember last year when I read Senate Bill 1 and I was like, oh my gosh, this is everything we've been doing for so long. I'm so glad the legislature is finally listening to us. And I think that there's this, there's definitely there's a lot of very positive momentum around health equity right now, which is fantastic. And I think what we've been trying to do as an association has really been to articulate what that means, because health equity is a great buzzword. And I think a lot of what we have been working on is shaping the conversation around what health centers need. And around making sure that, because we recognize that health centers are one of the primary access points for healthcare for communities of color, and giving health centers more resources will increase access to healthcare in those communities. So I realize that's a lot, and there will probably be more questions, but I'm so happy to be here. Thank you so much for having me.
Good evening. Good evening. My name is Sylvia Cooper, and I am a case manager for the Ministerial Health Fellowship Coach 2 program. One of my roles as a case manager, the targeted population that I work with is people of color and those who are challenged with substance use and mental health. I represent the Greater New Haven area, and I can tell you from 2 points that I'd like to introduce myself. One, working with the population who's so vulnerable, but also to a person who does receive Husky insurance, and making sure that people are informed about their choices, how they receive healthcare with dignity and respect, and making sure that people know who don't go to the doctors as often as they should, that they are cared for, that they're very valuable, and to hold their hands or guide them to make sure that they are healthy. I live in and work in one of the most vulnerable and poorest of the cities in New Haven, where the average household earns about $30-something thousand for a family of 3. And so there's so many people that we run into our organization and our work when folks tell you, I don't have a primary care physician, even in a COVID world. And a woman past 40 years old tell you, I haven't had a mammogram yet. And let's not go there with dental care. That is alarming. It's upsetting. And it is my mission, our mission, to make sure that people have access to care and that they know how to advocate for themselves.
Good afternoon, everyone. My name is Frank Cruz. Let me do this in Spanish. I'm more comfortable. Ya les decía, mi nombre es Frank Cruz. Soy residente de la ciudad de Bridgeport. Soy líder del comité de lucha de la organización Make the World Connecticut. Nuestra organización ha trabajado y estamos muy orgullosos de pertenecer a esta coalición y para poder trabajar para poder llevar a la comunidad a uno de sus, llevar beneficio a la comunidad, ¿verdad? Hemos trabajado en varias leyes juntos y esperamos seguirlo haciendo porque nuestra comunidad necesita muchos beneficios, mucha ayuda. Estoy orgulloso de estar aquí hoy junto a ustedes en este panel y muchas gracias por invitarnos.
Thank you so much, everyone, and thank you so much for introducing yourselves. Just want to remind us, because we are having, because we do have an interpreter, that we speak also slowly. So I want to go into our question and answer period, and I just want to say thank you. Thank you so much for all of the great work that each and every one of you are doing. I am, also so elated in terms of just the experts that are on this panel on tonight, and also the difference that you are making and continue to make in this, in Connecticut. But also, I believe that even what we do in Connecticut affects us nationally as well. So thank you so much. There are some questions that I want to ask you individually, and then I also invite you, as I may say something to one person, but please feel free to jump in if you have something that you want to add to that question. So the first question that I have is for Dr. Brinkley. I wanted to also have you elaborate and really talk about the fact that health care is a social determinant of health. And so how would you explain that to others, and how would you also really encourage them to lift their voices around that and to continue to remind people that healthcare is a social determinant of health?
Absolutely. So social determinants of health are those factors that have nothing to do with your genetic makeup that affect your health. So there was a study that found that you can predict people's life expectancy based on their zip code alone. So there's a difference in life expectancy between people who live in Greenwich versus people who live in New Haven. Just the zip code alone can predict lots and lots of different things about the health outcomes that people are more likely to have, or the risk factors that people are more likely to have. So things like access to housing, safe housing, access to transportation. So even you can count the number of broken windows or cracks in sidewalks in a community, and that can tell you a lot about the likely health of the people who live in that community. Education, job opportunities, exposure to violence, access to nutritious food. So do you have a supermarket that you can go to versus only having access to a bodega? If you have access to a supermarket, do you have to pick items that are high calorically dense, in boxes and lightweight containers, lightweight packaging, because you have to take 2 buses and you can't carry a bunch of cans, or you can't carry a bunch of stuff that will, spoil very quickly. So, access isn't just the fact that it's in your community, but do you really have true access? Are you actually able to take advantage of it and avail yourself of that resource? Is your water clean? Is your air clean? How literate are people in your community? What is the education level? And then also, how well are you buffered from racism, discrimination, and bias? That's a very, very big one. And you could see during the pandemic how racism, bias, the lack of culturally competent or culturally and linguistically fluent messaging, health messaging, prevented Black and brown people in particular from getting those early messages about preventing COVID and keeping themselves safe that really made a difference in some of those outcomes. So, you know, there might be posters in your community with health information, but are you able to interpret it? Are you able to digest that information? Do you see that as targeting you? Do you see those messages as actually targeting you in the first place? And so when you think about access to healthcare, we talk about the importance of, you know, prevention and early detection, and not having access to healthcare means that people are getting diagnoses when disease is more far advanced. So I'll use the example of breast cancer. So Black women, for example, have lower rates of breast cancer, but are more likely to die of breast cancer than white women. And a large part of that is because Black women tend to be diagnosed with breast cancer when it's further along. Okay, so you think about little delays in healthcare. So recently my insurance changed and I already had a mammogram schedule. So I tried to plan, I'm a December baby, I tried to plan it around my birthday. And just that changes in insurance, the hospital on their end, they couldn't figure out what my insurance was. So I looked like a self-pay. And the difference in the treatment I got when they thought I was insured versus when they thought I was a self-pay it was night and day. My appointment was just canceled. I never said I couldn't self-pay if that was the case, but my appointment was randomly canceled. I had to call back and say, well, why was my appointment canceled? And she said, well, you look like a self-pay. I said, well, did you ask me if I could self-pay? No follow-up questions. And so just the difference in treatment that I got when the assumption was that I didn't have insurance was enough to delay my care. So if I had not rescheduled the appointment, that could be the difference between life and death. So it's not just access to care in terms of having insurance, but the perceptions that people have of you when they think that you can't afford your health care. So how somebody with Medicaid may be treated versus someone, you know, who has private insurance. All of those factors, it's not just having access to something. So we kind of have to expand our definition of access. It's not just having something, but is it really connecting you with care, connecting you with high quality care in the way that it should? And sometimes that isn't the case. And so when you think of those social determinants of health, all of those everyday experiences where we work, where we play, where we live, and also where we worship, because, you know, some of the messages that we get about health also come from our places of worship and those, you know, informal communities that we're a part of. All of those things sometimes have a greater impact on the health outcomes that we experience or our risk factors than, you know, our genetic makeup. So it's not just, you know, there's diabetes in my family, but okay, there are other people who have that genetic predisposition, but don't end up having that outcome because they have better access, because they have better health options, they have better food options, they have better access to you know, spaces to exercise without the fear of violence. All of those different things really affect how you're able to experience day-to-day life and the health outcomes that you experience as a result of it. So that's what your social determinants of health are.
Thank you so much, Dr. Brinkley. And I understand, I was just thinking about even what you had mentioned before. I just recently changed insurances also.
It's a nightmare.
Oh my goodness, what a nightmare. And just in terms of the same thing that you said, I had tests scheduled, I had different things that were scheduled, and all of a sudden, it was like nobody wanted to talk to me.
Nobody
well,
wants to
what
talk
kind
to
of
you.
insurance do you have? You don't have any insurance? Well, you know, the
and
bill
you would
is
literally talk to the same people, the same nurse who helped you the week before when they thought you were insured is all of a sudden rude, all of a sudden abrupt, just very, very different reception. So we have to expand how we're talking about access. It's not just giving people insurance, but what the biases that people are experiencing. It's really, really unfortunate.
Yes, and imagine, you know I can afford, thank God, in health insurance, but imagine those that can't afford it, how they're treated. And I even remember I had a sciatic nerve that acted up. I was in so much pain that day, and they couldn't figure out my insurance. They couldn't call it, and I was kind of in between. She says, well, we're not going to even be able to see you unless you give us $350. I said, I don't care how much it costs at this point. I'm hurting, and so I will pay you.
Exactly.
Take care of what I need to take care of. We can handle the insurance later. But you're absolutely right. And, you know, really, when we think about that, that needs to change, that everybody deserves to be cared for, deserves to have health care, and it should not matter your zip code. It should not matter of the color of your skin. It should not matter who you are, but it should be that the most important thing is that you are attended to, and whatever your health needs are attended to. So thank you, Dr. Brinkley, for that. I could identify with you
Yep.
recently. I just want to mention that lately, and then I don't know if anybody else wanted to briefly say something about what Dr. Brinkley also said and add to the question or anything, but I know she was very thorough with what she had mentioned. If not, we'll go to the next question. And so just so you know, there was a Kaiser the Kaiser Family Foundation recently released a report. To me, that was alarming, that 30% of adults, which we all know this and we see this every day, cannot afford health care or associated costs. And so I know, Sylvia, you are out there in the community, as you mentioned, and you are working with people all the time. Can you really expound on that and that study that is so alarming to know that 30% of people cannot afford healthcare insurance or the costs that are associated with that? How does that play out every day in what you see in the community?
Yes, Reverend Robin. People are faced with many tough decisions. I think the opinion that folks have in the community, if you're on Husky or a paying into the marketplace of the health insurance, that you somehow don't fit into the regular population of people who can afford insurance. But there's a difference. So if someone's going to the dentist's office who is a regular pay at your current clinic, and they don't have dental coverage insurance because they only have medical, then they're forced to pay out of pocket. If they need to see an orthodontist or oral surgeon, then that money comes out of pocket. So let's say, for example, if Sue and John go to work one day and they get a flat tire, and Sue has this awful toothache and it needs work on, and they can save her tooth, but it's going to require some money out of pocket. But the flat tire that needs to be fixed, they find they need brakes. What do they have to do? Either Sue loses that tooth or the damage continues on in her mouth, but the car they have to fix because they can get back and forth to work, the store, take the kids around. And so there's no buffer, there's no in-between insurance for Sue to pay into a policy that she can actually afford to get the work done. People are making choices. Do I get this prescription this month? Do I split it in half? Because I really can't afford the copay. And so people are making very dangerous decisions about being healthy and about what they can afford. And no one wants to take away from the rent or the light bill, but they will compromise medication. They will compromise not seeing a specialist because the out-of-pocket expense is so high. And they need better plans. It has to be a better plan that people can afford the out-of-pocket expenses. It's lowered, or people can at least know, working with a doctor or a specialist, is there a payment plan that you don't want all my money up front? Can I receive services and have a sliding scale payment that I'm able to receive quality care without compromising so much of my life? And our message continues to be is advocacy is a powerful thing. Having people talk to their care providers, their healthcare providers, what are my options, and never make assumptions. Because I found out myself today, just at the dentist, I was having just an evaluation for 15 months, and she looked at my teeth and she says, "You're due for another cleaning." And I said, "No, Husky only pays for once a month." She said, "No, we just found out that you have a pre-existing condition and you can have a second cleaning this year." What a powerful thing that I found out. So what am I going to do with that information? Just have my teeth cleaned next month? Or I'm going to tell other people, hey, guess what I found out? I'm going to share this information so it doesn't stop with me, so it empowers everybody else. That's a wonderful thing about advocacy. Tell the story, share the information so more people can become informed. And I love that work we do with MHF. I love it in my personal life. I love it in the church, because one piece of information can change an entire life.
Thank you so much, Sylvia. And thank you also for sharing that in terms of people make decisions and compromise their health every day because they can't afford costs. And the other thing that I also remember even having a member who, was really afraid, was in a lot of pain, but was concerned about going to the hospital because she had not paid her insurance premiums because she had some other pending measures that she was trying to take care of, mainly food, and she had lost hours because she was sick. And I told, you need to go to the, so we talked about it, asked her, I said, well, go to the hospital. Well, she got to the hospital and 3 hours later, she was in the operating room having emergency surgery. So those are decisions that people make every day. Did anyone else from the panel want to add to that or with that question? Are those results of people making those decisions every day? Okay, well, thank you so much. Sarah, oh my goodness, you are in a wonderful, wonderful spot, I see, in San Diego. I love San Diego. It is so beautiful there. But I'm gonna be honest with you, I see your dedication and commitment to the work that even in beautiful San Diego on vacation, you are here on tonight with us. So, good, great. But I want to ask you the question around the fact that, we know that the high healthcare costs disproportionately affect Black and Brown people. And especially those who are in lower income brackets, and those who are born in the United States, but also those that are born outside of the United States. What can we do? What can we do to, and what does the Community Health Center do to address those concerns and those needs?
Great, and it's lovely to be joining you all from beautiful San Diego. I feel bad because it's so, like, I was going to take my meeting inside, but I was like, it's so nice. It's gorgeous here. But
it's raining here.
I'm going to come back and my garden is just going to be filled with flowers, so I'll take it. But to answer your question, I think. So looking at our health center patients, I think it's something like 60% of Connecticut's health center patients are at or below 200% of the federal poverty level. What that actually means is that most health center patients are families of four making less than $60,000 a year. I haven't looked at the federal poverty level, but that's roughly, I'm on vacation. I haven't looked at that chart recently, but so really affordability is an incredibly important thing. And it's very, I think also health centers exist in places where there are low concentrations of health professionals. So what that means is that we set up shop in the places where there aren't any doctors or dentists or therapists. And we do this with federal grants and other things that, and state grants and other types of funding that allow us to help our communities access care. And so, and additionally, health centers, they work very hard to make sure that healthcare is affordable to all patients that walk through their doors. I think last November, we trained over 70 enrollment specialists throughout the state to help people enroll in health insurance on the exchange. We have dozens and dozens of certified application counselors at all of our health centers that either help people enroll in Medicaid if they qualify, or they will help direct them to a plan that they can afford. Health centers also, they work with it for patients who are uninsured. They work on what's called a sliding fee scale, which they have access to under federal grants and things like that. And under the sliding fee scale, they help patients, they sort of work with patients to figure out what their income level is, and then they base sort of plan for payment on that. With that said, though, health centers don't turn patients away based on ability to pay. So I'm not going to say it's free healthcare because it isn't, but it's low cost. Additionally, we're actually working on a bill in the legislature right now that will protect access to prescription drugs. Health centers have the ability to participate in the federal 340B program. What that means is that they can help their patients access low-cost prescription drugs through a special program that's been set up by the federal government that's used to stretch scarce resources across the wide expanses where health centers serve. So health centers have a lot of options that help patients afford their care. And to kind of put that into perspective, recently the Center for Medicaid Services, they have been working on producing a new rule about surprise billing, and it's been a challenge for health centers because from the standpoint of the way that they provide care and the service that they offer, it wouldn't necessarily apply to them. So an example of this is under this new surprise billing rule, it would only apply to patients who receive bills of $400 or more. And health centers very rarely bill patients for that amount for anything. It's infrequent. I'm not going to say it doesn't happen, but it's infrequent because they work with people to figure out sort of what their cost of care will be. And I'm so glad that Sylvia brought up dental care because that's something that health centers, we've been working very hard to make sure is accessible to patients. Patients do have access to same-day dental services. It has been difficult to find the staff and resources to provide the level of care that patients need. But health centers do offer dental services. We do generously encourage people to come in to get cleanings and to get the treatment that they need so that we can save those teeth. I myself experienced a ridiculous dental bill when I was in college and didn't have good health insurance. And figuring out how to afford an $800 dental bill when I was working part-time was incredibly challenging. I had insurance, but it didn't matter because I had gone for 6 years without a cleaning, and after 6 years you need extra work. So I hope that answers your question about how to improve affordability. I think you may have also asked about additionally, like I said, health centers, they work with patients to figure out how to get care. I will note that their resource, their staffing is limited. Health centers want to be able to offer as many services as possible, but they're often limited by the capacity of their health center and their staff. So it's a lot of times when someone needs a specialist, they'll have to do a referral, and that, we wish that there were more specialists available that, could work with health centers. That's just not, unfortunately, it's not the reality of the world that we live in. But thank you for that question.
Yes, thank you. Thank you so much, Sarah, also. And one of the things, like you said, it is affordable, but also healthcare centers also, take in people regardless of their ability to pay. And so that's for persons that are also born in the United States and also those that are not born in the United States as well, which is very important that people feel that they can also go someplace, whether they're born here or not, that will actually tend to their medical needs. And so I think, community health centers are so key and so important with that, because we do know also that, one of the things that we have also been advocating for affordable healthcare is healthcare for immigrants, also Husky for immigrants. So that is, one thing that I think about also, and just the fact that they're in the community and it's more community based also. And I have some great friends that are president and CEOs of healthcare centers in Connecticut. So I know the work that you all put in and the hard work that's put in there. So thank you also for what you do. Is there anyone else that also on the panel that would like to also speak to that question also as it relates to community health centers that you see also of the great work that's important? And I also wanted to say too, I think that what Dr. Brinkley had also mentioned earlier about how COVID-19 is and the disproportionate amount of people that are actually died. And one of the things, I even said this to the governor the other day, that really floored me and I was really kind of appalled at, was the fact that they couldn't even give statistics of the number of people that were dying because of the way that they were collecting or non-collecting data. But also the fact that Black and brown people were very vulnerable and also not having that kind of information. And so that was one of the things that we immediately wanted to make sure, and that's a lot of the work that we did. We knocked on people's doors, gave them wellness kits, gave them educational things, gave them supplies so that they could protect themselves and actually know about that. And I was going to say one thing the community health centers I know also did they went out, in their vans to vaccinate people and to also test people as well out in the community. So thank you.
Yeah, I'll add to that if I may. Health centers off, I think since August of 2020, they've done nearly 1 million tests throughout the state, and they've fully vaccinated almost 400,000 people. You are correct in that COVID disproportionately affected Black and brown communities. I will also add that part of the reason for that is Black and people of color were more likely to experience adverse health effects as a result of COVID-19 because, of what we've been talking about, or sort of what's related, the social determinants of health. And I think it's important that people understand social determinants of health. I always find it helpful to illustrate what that means. That means that there are more children born into these communities with asthma. That means that that these communities experience diabetes and hypertension and heart disease at a disproportionate rate. That is what we are talking about. I think that a lot of the times terms like social determinants of health and health equity they become these buzzwords. And I always try to bring people back and explain this is what that means. That this means that people are experiencing these long-term chronic health conditions that impact their entire quality of life. And the reason that they are dying at a higher rate of COVID-19 is because they are also experiencing these comorbidities in many cases. And that is part of why that statistic exists. I'm also frustrated at the lack of that there, wasn't necessarily enough data collection. I think that a lot of my frustration was that I felt like the advocates for communities of color did not receive as much concern from the powers that be during the pandemic. There were a lot of good things that happened, but there were many times when I felt like the voices of those who were advocating for those communities did not get enough attention.
You're absolutely right. And we can go on and on with that all night. So I'm going to move. Frank, you've been so patient. So I want to also ask you a question on tonight also. And I know that you have been soaking in everything. And I want to salute you for being the only male on tonight as well. And so we're so grateful and thankful also for you. And so I want to ask you about SB 284, which was a bill, an act that basically looked at the age of immigrants or persons 8 to 18 years old, expanding that age. We know that Husky for Immigrants, that it was a bill that was passed, a policy that was passed that 8-year-olds could do it. But also this time, that bill also really looked at being able to expand it up until the age of 18 years old. Can you can give us in the real world, what does that really mean? And in the real world, how effective is that and how important is that bill? Because I'm like Sarah, sometimes you got to just tell the story.
Sí, bueno, muchas gracias. Igual, sobre la ley, la propuesta de ley SB 284, esta propuesta fue introducida por los legisladores para expandir el HOSKI para niños indocumentados de edad de 9 a 18 años de edad. Nuestra organización tuvo un trabajo duro, un trabajo en equipo. Tuvimos 360 testimonios escritos y 200 testimonios virtuales, donde miembros de la comunidad esperaron hasta las 10:30 de la noche para poder testificar ante los legisladores. Estamos muy tristes que nuestros legisladores no vieran la urgencia de poder aprobar y expandir esta ley. Nos sentimos muy tristes porque ellos siento que nos fallaron, ¿no? Creo que nuestros legisladores tienen la oportunidad de transformar una ley y ser los pioneros en este país para poder dar acceso médico a nuestros jóvenes. Es muy triste ver cómo año con año este país gasta billones en aspectos de gastos militares y no pueden resolver un problema que es la falta de seguro médico para la población indocumentada. Recordemos que nuestras comunidades negras y latinas fueron las más afectadas en cuanto al COVID. En cuanto a los jóvenes, esta ley ayuda a que los jóvenes hasta la edad de 18 años puedan tener acceso y ayuda a que ellos se puedan concentrar en sus estudios, puedan buscar mejores beneficios en su vida. Al no tenerlos, hay muchos jóvenes que optan por dejar las escuelas, dejar los estudios y comenzar a trabajar. Hablo usualmente de la comunidad latina, ¿verdad? Pero estamos... nuestra lucha no termina aquí. Como organización, como Make the Road y como coalición, vamos a seguir peleando para que nuestros niños, documentos, tengan acceso al cuidado médico y vamos a seguir las conversaciones. No pararemos de luchar hasta ver que se expanda el acceso médico para todos, sin importar el estatus social o el estatus migratorio. Otra vez les quiero hacer un llamado a los legisladores. Somos una comunidad muy golpeada debido al COVID. Hemos tenido ahora mismo dentro de la comunidad, sabemos de casos de personas que están sufriendo o problemas de salud mental, los jóvenes, es más que todo, es una oportunidad que los legisladores tienen en su mano para poder reconsiderar que esta ley SB 284 es muy importante para nuestra comunidad. Le agradezco a ustedes, a este panel, por dar una oportunidad a nuestra organización y a esta coalición. Estamos orgullosos de pertenecer, de apoyarnos y esperamos seguir trabajando siempre con ustedes. Muchas gracias.
Thank you so much, Frank, and also, thank you also for, and it is true that that's why I said we're all in this, really together, and it is important that everybody needs healthcare, and that we are all of us contribute to this nation, to this world, to this city, and to this state. And that our children, as well as adults, all of us should always have health care, no matter who we are, and no matter, that we are, people of color, no matter where we come from. That if we are here, we need to have health care. We need to have affordable health care, and certainly should be for our, be able to have our children also to be able to receive the health care, as well as their parents, because children can't take care of themselves. They need their parents to be healthy as well. So again, thank you so much also for the work that you are doing. Does anyone else want to add to what Frank has shared today?
So just to add, I think one of the points that's really important to highlight is that, we live in a developed nation, and oftentimes the health outcomes that people experience tend to be chronic disease outcomes. So it's very easy for us to think that people's health is their own personal problem, their own individual problem. But I think one of the lessons that COVID taught us was that we really are all interconnected. So your child is going to school with a child who couldn't go to the doctor, who may have been positive for COVID, for example, or whose parents, could take off time from work, but they couldn't go to a doctor or couldn't get access to a test, or they couldn't social distance in their living space. And so all of a sudden we had some of the issues that developing nations have had to deal with around infectious diseases and having to have more of a community sort of focus. We had to grapple with that during COVID, and you really do realize that having groups of people who don't have access really affects us all. And so we really can't think about health as an individual problem anymore, regardless of if we're talking about a chronic disease or an infectious disease. We are all affected by each other's health outcomes.
So true. We all live here together. That's why I said we're all in this together. Yes, thank you. Definitely. Okay, anyone else that would like to add to that or what Frank has shared on today? Okay, the next question, I think all of you can answer, but also to Dr. Brinkley, I know you kind of alluded to it also when you, started speaking, but there's evidence that, we talked about today, accessing healthcare is based on income, for income eligible people is confusing and also burdensome. There is also evidence that community health workers and or patient navigators can reduce the burden and confusion in addition to educating people about their healthcare options. So Dr. Brinkley, if you would speak to that and the rest of the panelists to really speak about CHWs, and I know you mentioned a little bit in navigators, how important that is to help with this burdensome system of people not understanding what they have access to, what they are entitled to, and how do they gain access? How do they advocate for themselves? How do they deal with language barriers and those kinds of things that not always get them being able to understand what they have or to be able to access what they have? How are CHWs and navigators so important? And so we'll start with you, and then everybody else can kind of chime in also, because I know everybody has, can add to that.
Yes, so CHWs are such an invaluable resource because CHWs understand the context of a patient's life. So you go to your doctor, and all of us have been to the doctor, and regardless of our educational background, a doctor's visit, especially when you're sick, can be so overwhelming. There's stuff that you want to ask them. You feel so intimidated a lot of the times. And what CHWs, also known as navigators, also known as promotoras or promotores, there are lots of different names that CHWs go by, but what they do are two important things. They are advocates for the patient, and they also are able to sort of provide some cultural context, linguistic context, social context for what the patient is experiencing. So I'll give you an example. So let's say the doctor, and one of the things that people always talk about, the ways that community health workers help the patient navigate the system. One of the most important things that CHWs do is educating physicians, providers on the real lived experience of the patient. So for example, a doctor may be really frustrated and say, oh, these people are they're not very compliant with their medication, or this patient is very, uncompliant. She doesn't take the medication as requested. I've explained to her disorder and why it's so important for her to take her medication. But what the physician may not understand is if that patient is food insecure and you've prescribed a medication that requires you to take it with meals, that patient, even if they want to take their medication, they're not going to be able to take that medication because they literally don't have the food to take that medication with. Or you have that 15-minute window or your appointment gets canceled. Well, someone is taking 2 buses to get to the doctor's office, and the doctor feels like, well, that patient just keeps being a no-show. No, that first bus was late, and it set off a whole chain of events. Plus, they're missing their income for that afternoon because they don't have paid time off. And so they're arriving at a doctor's appointment 20 minutes late after missing an afternoon of pay, after taking a couple of buses. And from the physician's perspective, they were just a no-show. Or just even the ways that people respond to questions. So I'm from the Caribbean. So if someone said to me, did you bathe today? Now for us, bathe means anything, shower, sitting in the tub, anything that has to do with washing your body. Caribbean people call it bathe. But somebody else from a different cultural context may make the distinction between a shower and a bath. So they may say, oh, I didn't bathe today, meaning that they didn't sit in the tub and soak, but they took a shower. So a community health worker from that neighborhood can say, or from that cultural group can explain, oh, no, this is what this person meant when they said this. Or this is why this person didn't respond well to you because you made too much eye contact or too little eye contact. Those little cues allow the patient and the provider to have more effective communication between themselves. And then, that's just the patient-provider interaction. But then in terms of the whole social piece, the whole access piece, community health workers, they understand the neighborhood, they understand the barriers that their clients are facing to access healthcare, and they're able to help the patient navigate, as the name implies, navigate the transportation issues, navigate, the fact that it may be difficult to go to one provider and get appointments after work. Help the patients navigate, the fact that, now you're eligible for a second cleaning at the dentist's office, giving them that information, explaining what the physician said within a cultural context, explaining additional pieces of information that the physician may not have had the time to explain, all of those different factors. Because what physicians, well, I shouldn't say what physicians lack, but what community health workers definitely have is trust with the client in a way that other members of the healthcare system may not have had the opportunity to establish that level of trust with the patient just yet. And so patients feel more comfortable explaining what's really going on behind the scenes. Community health workers feel more comfortable asking questions that a physician may not be able to ask. And so when you put all of these little pieces together, it makes for a situation where the patient has better access, better quality of care, and feels more empowered when navigating their own health situation. So that's really why community health workers are so important.
Definitely. So important.
Mm-hmm.
Okay, anyone else want to add to that? Okay, all right, we'll go to our next question. Sarah, I know she's still in San Diego, but I believe that she could actually hear us, and I'm sure she'll come back. But anyway, regarding education, regarding educating people about their healthcare options, SB 34 was actually about covering Covered Connecticut, which is I'm sure all of you heard Cover Connecticut. And so one of the things about SB 34 was really to really promote raising that income level up, because we know that I can speak to that a part of that is that as the minimum wage continues to go up, then persons' income levels continue to go up. And therefore, it puts them in a predicament in which they no longer are eligible for Husky or for free insurance, or their actual premiums can go up. And as we all mentioned today, you make that choice to either eat or pay your premiums. And of course, we're going to eat. So based on that Covered Connecticut program, but also, again, as we talked about, really making sure that we have navigators also that are a part of it, that can kind of help people to, because once these bills are passed, who tells them how to access this? Who tells them how to really enroll people? And so can you just, Sarah, if you can just tell us a little bit about the bill and, how can the community health center educate parents about coverage? How do you educate parents about coverage? Or either all of you can kind of chime into that. How do we educate people? How do people know how to get access if we don't have? And one of the things that's another thing that community health workers and navigators can help with. But what kinds of things would you say that we need to do to make sure that people really understand what they have access to? Because I also believe that would also add to our advocacy capacity. If people really understood some of the barriers, then they can help others and also could also chime into and be a part of the advocacy work that all of us do. So I think all of you can probably speak to that.
Okay, I think you're on mute. Yeah.
Sarah? Okay, she may have had to step away. Does someone else want to answer that? Please feel free to chime in.
Well, I think that, education is really, really important, but, we have to make sure that the education is at the appropriate level, has to make sure that it reaches people where they are, we have to make sure that it is, that people see that the message as being targeted towards them. So sometimes you have a health message and you think that it really will reach a certain population, but they don't see them, they don't identify with whoever the health message appears to be for. And then, we have an issue with literacy also. Most health messages need to be at about a fourth grade or so reading level because, a lot of times people just don't understand complicated health information or find it really hard to interpret because you can read, two people can read the same sentence and see it so differently. And so you kind of need messages to be delivered lots of different ways for it to stick with people. We can use social media, although social media is also a source of a lot of misinformation. But you can use social media, you can use written messages, you can use television messages. But some of the most effective education is peer-to-peer or person-to-person. And so, if you can educate one person from the community who has influence and is able to spread that message, then that is one of the best ways to get health information out that can help people access healthcare effectively in their own communities.
You're absolutely right. And I know Sylvia can kind of speak to that, even about the amount of people that she has encountered, even in the community, and really helping them to understand what they do have access to. And so maybe she might want to share something or share a story about that as well.
Reverend Robert, can you repeat that again, the story?
Yes, we're talking about now, and anybody can chime in, but I thought maybe you want to talk about it from even the work that you do every day. And Dr. Brinkley has kind of really talked about some ways in terms of, and I agree, I always say this, Dr. Brinkley, put it in layman's terms that they can
make it
understand
simple.
Give them the instruction that they can go from point A to point B to point C and make it so that it's eye-catching and but anyway, we're just talking about also, and I thought maybe you might want to share about also even persons in the community that you have come in contact with that don't have health care, but don't know that they could, that they have access to different things, but may not know that they have access. And how do you work with them? How do you get them to that? And what kind of suggestions would you make to make sure that people understand and what they have access to?
So very good points, because we take for granted that people, even when they read at a low range of understanding and no high school diploma or GED and language barriers, that people don't read with understanding. And it's a lot of language. Like when it's time to renew your Husky insurance, it's saying a lot of words there, but what is it really saying? And so helping people complete applications, putting tougher demands on our legislators to say, listen, it has to be a better way that people can understand what kind of insurance do they have. A lot of people don't know that from my understanding, when I read it, that if you come into some money or you want to better yourself with assets and property, that the state can attach that and take your assets and property away from you. And so people need to understand what they're signing on to, but also too, basically just the once a year health coverage that you can have your once a year physicals at certain ages, colon testing and colonoscopy for men and women, and understanding like it's okay. And sometimes it just takes in our work, just saying, do you need help understanding that? Do you want me to go to the appointment with you? Do you have any questions that you think you're scared to ask? And I can sit with you. Now that's not easily, and that's achievable every day, but people just they want you to connect with them. I have a hard problem understanding some of this stuff, but a question not asked never gets answered. And being partners with our community members and saying to them, you know what, I understand what you're saying. When you go to the doctors before you see them, when I see my neurologist, I have epilepsy. I have to answer all of these questions with a clipboard. Do you have headaches? Do you experience tingling in your arm and numbness and muscle aches? And by the time you get through it, you can't even see anybody yet. But I'm like, oh my God, do I have tingling? Do I have numbing? Things like that, and blurred vision and all these things. Whereas someone who quite may not understand that, it's just a profile they're asking you for to make sure that they're understanding how you feel with your next appointment. I believe in a buddy system. And I know it's COVID, we can limit to what we can do because of restrictions, but it's okay to have a buddy pal, a health buddy pal, to go with you. So some people have anxiety going to the doctors. They're sweating in the cars like, oh my God, what are they going to tell me? What are they going to say? So I highly recommend that, as we spread our message of change agents and support in the community, that encourage people to find someone that you really trust that can help you understand the language and healthcare, but also too, to help you through the process of going to the doctors with you, especially when one time I had a mammogram and they said I had to come back in. They gave me nothing else. You got to come back in for ultrasound. And I'm like, oh my God, the first thing I'm thinking, I have breast cancer. And also to educating your providers, you have to do a better way of communicating. With EEGs, I went and they put this glue in my hair and I had locks. I had, locks, and I had to take the Barbie pins and things out. And I said to them, this doesn't speak to people and women of color. We wear pins and we wear our hair braided with synthetic hair. And maybe you want to tell us before we come to wear rubber bands and pin our hair up and take heavy metal clips and things we have in our hair to make the visit less complicated, where we spend 20 minutes trying to take Barbie pins out, because understanding cultures. And so what I just suggest things, fill out your patient surveys, fill them out and tell people what you have experienced, what you did not like about the experience. They read them. And so that's been my experience. And as we continue to be change agents and help people partner, we just continue to spread the message.
Yes, definitely. Just to add, giving feedback. Also use patient advocates at the hospital. Give, if you've had a negative experience, use those patient advocates so that the hospital itself or the healthcare organization is aware of the treatment that you receive. Those are, yes, they help you navigate your visit as well, but just like filling out the surveys are important, let patient advocates know if you've had a negative experience. And to the point about destigmatizing not knowing, that's such an important point, because everyone assumes that people know, the other person knows more than them. And I had a recent experience where, we all got those free COVID tests in the mail, and, my son was a little sniffly. So I said, okay, well, let's use these COVID tests. I have never felt more confused. And it's a simple procedure in theory, but I was so confused. I'm 100% sure I didn't do it right. If any of us had COVID, we wouldn't know. And it's something that you would think would be so simple. It's a simple little test. So everyone I've spoken to, I said, you know, have you used any of your at-home tests? It really is not as easy to use as you think. So don't feel bad if you can't use it. So little things like that, just destigmatizing, not understanding, not knowing stuff can really help people create that buddy system to help each other as well.
Mm-hmm. I totally agree. And I was just as lost too with the COVID test.
Oh my goodness.
For the record, like, you know, not only have health centers been offering COVID tests, but we have a community, we have like health workers in our own staff that are out there telling people to get COVID tests, and I didn't understand how to do it. So it's, you know, like, it's not that I didn't understand. I was there. The instructions are very involved. And I'm sorry, I had a parenting emergency, and I'm sorry if I missed a couple of questions. Okay. But I'm actually really glad that we're talking about accessibility and communication. And one thing I will, and I think that Sylvia brought this up, that I think there's a really strong need to have more providers of color, and one of the things that we're working on at CHC, sort of from a more global perspective, is increasing primary care workforce development, and figuring out how to diversify the primary care workforce. Because if Sylvia's provider was a woman of color, she probably would have known that, you know, if someone comes in with locks, you've got to remove the bobby pin, you know. So I think that there's a really strong need, and because that, you know, you can have someone who's very qualified, you can have someone who has a ton of impressive degrees from excellent universities, but if they have not lived the experience that a person of color has, there are going to be things that they will miss. And I think, you know, as much as organizations try to do sensitivity training and other things, I think that the reality is that there need to be more. We need to do a better job of recruiting and retaining providers of color at our medical institutions. And I think a big portion of that, and actually something that that we've been talking about for a while, is the impact of student debt and the impact that that has on the decisions that people make as to whether or not to continue their education. Last year, we worked with the governor's office, or we worked with the legislature on reinstating the state loan repayment program, which offers loan repayment grants to providers working in health centers. And the governor's budget actually vastly increased the resources for that program. So I sincerely hope that we see a lot more students of color entering medical school, and getting sort of elevating themselves. Or that I realize that that's a bold goal, but I think that one thing that we can absolutely do to increase access to care, improve communication in the healthcare field at all levels, is to get more people of color into those professions. I think the same thing goes for insurance. If we have more people from communities that need better health insurance working in health insurance, it will improve the way that communication happens. And it's something, you know, that we don't often see, but it's a really important piece of providing care and improving healthcare, is encouraging diversity and in those circles, encouraging diversity in not just you know, in the, you know, person to person interaction, but in all places where decisions are made. I think it's incredibly important that the larger corporations that are overseeing a lot of these changes in healthcare and overseeing our healthcare have representation in their boards. That's a conversation for another time, but that's one thing that I think if we can push the needle and push those conversations to include more diverse voices, and insert ourselves when there is no space at the table. And, you know, speaking as a white woman, I can't insert myself into those conversations, but encouraging those spaces to open up to diverse voices will improve our healthcare system. And
I totally agree. I think she dropped. But I also think that one of the things that I would also say also is really making sure that we have persons of color that are at those tables in the boardroom and in corporate America that are also advocating for, and being able to, really lift their voices up also. Because whether, and we don't like to really talk about it, but underneath all of this is racism. And until we really deal with systemic and structural racism, we'll just be talking, And so, and a part of that is to make sure that we have access, we have shared leadership also, and we're in the place where we can do some decision making, also, and, and policy changing, also. As well. Frank, I just wanted to make sure, did you have something that you wanted to add to that in terms of what you think about how, we can get the message across and how people, not only would know what they have access to and helping them to navigate that system to gain access? Did you want to add anything to that?
Sí, muchas gracias. Afortunadamente he estado escuchando a nuestros panelistas y he estado recibiendo mucha información y de acuerdo con ellos, muy desgraciadamente, es cierto, nuestras comunidades negras y latinas, desgraciadamente, carecemos de información a la hora de asistir a una cita médica, por ejemplo, como hablaba una de las panelistas. Nos da miedo preguntar, nos da miedo a veces inclusive hasta asistir a la misma cita médica, porque a veces nos da miedo, como pongo un ejemplo como la comunidad latina, a veces nos da miedo hasta darnos cuenta de la enfermedad que podamos tener, aún no teniéndola. Entonces, y también miedo a cuánto nos va a salir un bill de la visita al médico. Eso, la mayoría de personas de mi comunidad, de eso lo que estamos tratando de llevar información adecuada, la información que puedan ellos tener acceso en un hospital, a conversar con una persona calificada y poderle dar la información a él a qué beneficios se pueda obtener, qué los procedimientos que él debe seguir, cómo debe ser el tratamiento que debe tener y también obtenerlo en su lenguaje, porque tenemos ese también problemas a veces que falta de personas que puedan tener acceso a atención en su lenguaje, en su idioma. Entonces, una barrera grande que estamos tratando de hacerle ver también al sistema médico en nuestra ciudad y en nuestro estado. Muy de acuerdo con todos los panelistas, es una misión muy dura. Escuchaba a nuestra compañera Silvia, ha sido cosas fuertes, o sea, que desgraciadamente hemos sufrido porque al tener la falta de acceso a todos estos recursos, no preguntamos, no escudriñamos, no tratamos de ver qué los beneficios podemos tener, ¿verdad?, en el servicio médico. Muy de acuerdo con todos. Muchas gracias otra vez por tenernos aquí y muchas gracias por dejarnos participar.
Yes, definitely. Wonderful. So I tell you, time just goes by so fast, and we are having such a great conversation, but also some great nuggets and some important things that we have discussed on tonight that I hope that those that are watching have heard and listened to some of the things that we are saying. And also, not only will you lift your voice and become advocates and join in with all of us as we continue to do this work. It's not always easy, but you can. But I do believe that together, that we're able to, make a difference. Together, we're able to push policies through. Together, we are able to advocate what is needed to help people to gain access to affordable health care and to know what they have access to and to be educated about the access that they have, and also to have persons that look like them, that know them, that are able to speak their language, to be able to be with them side by side as they provide, gain access to these difficult systems. But as we get ready to systems that sometimes, as we even mentioned ourselves, that we think we know the systems well, but it's still very difficult to navigate them. And so navigators are needed. Community health workers are definitely needed. And so, before we leave here on today, I'd like for each of you to share what you would like everyone to leave with on today, as we come to a close of this wonderful, great session. And I'm telling you, I thank you so much for the phenomenal work that you're doing, and that's the expertise that's represented here today. I feel humbled and honored that I was privileged to moderate this conversation on tonight. So what is your lasting things that you would like to say to people tonight, to the audience tonight, and those that will be listening?
Reverend Robin, I'd just like to say thank you for considering me worthy to be a part of these great individuals, part of this so much needed continuing conversation about healthcare. My heart's desire is that people be well and healthy and knowledgeable about their healthcare providers, their insurance, and the fact that we can live a good life even with health conditions if we understand what's available for us. And preventive care is so important. And the fact that as we age, we need more preventive care and much knowledge about, just fruits and vegetables are good, but also about ways in which our body changes as we age, and more about genetics. People knowing more about their family's DNA, even if they don't know their families. That's a great start. But I appreciate and humbled by the work that I do with MHF and how we impact people, whether it's mental health, recovery, substance use, across the board. And that I believe that we can be healthy, we can be well, even if it requires us to change laws. So thank you again for this opportunity.
Thank you, Sylvia.
Yes, I agree. Thank you so much for having me today. This was a really great panel to be a part of, and I'm excited that there are so many people, doing this important work. And I think my takeaway, or the thing that I am optimistic about is, when you hear that, your zip code can predict your life expectancy, it sounds very negative, but the good news is if we actually improve some of those social determinants, and everyone can have, as Sylvia said, everyone can be well. These are things you can't change your genetic makeup, but we can change the quality of neighborhoods. We can change people's exposure to violence and the quality of people's air and water. And we can, start chipping away at some of that structural racism that's, sort of looming in the background and driving some of these things. So that in terms of, just on an optimistic note, social determinants really do impact your health outcomes, but these are things that we can change. That where we work, where we live, where we play, good policies can make life healthier and better for all of us. And if we really work together and stop thinking on such an individual basis and really start thinking about being in community with each other and caring about each other, there really is a lot of good that we can do in terms of our own health and the health of others. So I'm trying to be optimistic about what the future could hold for all of us.
Thank you.
I can go next. So there's one thing I give to all advocates, and it's when something isn't going the way you want it to, you should make noise and take up space. Mm-hmm. And I think that a lot of the things we've talked about here are really part of the result of a lot of frustration with the current structure. And before I was working at the Community Health Center Association, I worked in the legislature. And one thing I noticed was that it usually takes about 3 years to pass a bill. Sometimes you get lucky and it takes less. so it's important to remember that change takes time. It does not happen overnight, but the people making the decisions about the changes that are being made are the one they need to have input, and they need to have input from the voices that are being affected by what those changes are. And I think I have this Audre Lorde quote on my desk. It's self-care is not self-preservation. It is an act of political warfare. And I think that's often appropriate for these conversations about health equity, that we can't move forward if we're not willing to put ourselves out and make the noise and take up the space and move the things that need to move, even if they don't want to move. It's not unusual for things to break if they don't wish to bend. So that is what I will leave you with.
Thank you. Frank, anything you want to leave us with, or you want to say tonight before you leave? Any parting words?
Sí, bueno, de acuerdo con todos, lo que quería decirles es si la salud, el acceso a la salud es un derecho humano como tal, nosotros debemos de exigir a nuestros legisladores, a nuestros gobernantes, el derecho a tener un acceso a salud digno, a seguros médicos de bajos costos, y también pues decirle a las personas, nosotros como comunidad debemos de también cuidar nuestra salud, nuestra salud mental ante todo. El COVID nos ha traído muchos problemas, tanto económicos, médicos. Entonces, todo esto, la comunidad tiene que buscar atención y de repente asesorarse, buscar ayuda. Yo creo que la hay en nuestro estado. Hay mucho dinero, por decirlo así, muchos beneficios que la comunidad pueda tener acceso a él. Lastimosamente no los conocemos, pero para eso estamos hoy aquí. Para eso estamos aprendiendo como panel, como comunidad, empoderándonos para poder llevar esto a nuestras comunidades, a nuestros amigos, a nuestros hermanos, enseñarles, mostrarles la manera adecuada cómo obtener acceso médico para beneficio de nosotros mismos. Gracias.
Thank you. Thank you so much again, also to our audience on Facebook, and also those that are in the Zoom room and also on YouTube. Thank you all so much for joining in with us on today. And certainly we want to invite you to really continue to be in this, this movement to really be able to advocate for affordable healthcare, access to healthcare, also for all persons, especially people of color, as well as those that are born in the United States and those that are born outside of the United States. And I do believe that we together can certainly make a difference. And so please, whatever way you can, you see these great experts, the people that come from various organizations, please link up with them, join them. I'm sure they would be more than happy to have you join some of the efforts that they're having, along with health equity for the people, by the people, coalition, also any of those persons that are part of that health equity for the people, by the people. We were glad to have you and would love to have you come and join the advocacy efforts that we continue to have, and bills that we're looking to push forward, so that the things that we talked about tonight, the important things around affordable health care, CHW, navigators, also being able to have access to healthcare, and also, as we talked about, the many other things that would break the ceiling, that would allow us to really not just talk about it, but that we would see that we would make an effort to really break down those barriers that continue to allow systems to not be so friendly and not be open to the needs of people, especially around their health care, but most of all, also to be able to break down systemic and structural racism that continues to contribute to our healthcare system as well. So thank you again for tonight, for joining in on tonight. We'd love to have you join it. In the chat, you will also see links on how you get in touch with all of the persons that are from the coalition, as well as those that are here tonight. And then also we invite you to also, in the chat, there is a link that you can fill out the survey to let us know what you thought about tonight, what you took away from tonight. And we would love to have you even put in the chat, what is your takeaway? What is your exit? What are some of the things that you want to make sure that you do as you exit this great, I believe, seminar on tonight, and also the things that have been shared with the panelists? I'd like to have what I call exit slips. Tell us what are you leaving with? What are some of the things that you declare that you're going to do to really make healthcare affordable, and lifting your voice and helping to advocate for those that may not have a voice, but also you continuing to be a part of the movement that will provide that. And I believe we can do it. I believe we can do it, but it's going to take all of us coming together. So again, thank you again tonight. Please put in the chat. We'd love to hear from you in terms of how you're going to move forward as you heard this presentation on tonight. Thank you again, all of you great panelists on tonight. Thank you for everything you do. Let us continue to work together and keep moving forward. Thank you.
Thank you. Bye, everyone.
Bye-bye.
Muchas gracias a ustedes.